to know, have a taste of the audience. So, how many of you use endoscopic tattoo? Can you raise your hands if you use endoscopic tattoo? Okay.
Кто использует татуаж, пожалуйста, поднимите руки.
40%, 35%, okay. Who using the endoscopic tattoo? Do you inject tattoo directly?
You mean directly to Alberto? You mean?
Yes.
You mean directly into the lesion or?
In the mucosa.
In the mucosa.
Without fissure.
Кто непосредственно инвестирует в слизистую оболочку?
Okay. Thank you. So today I will briefly introduce the topic, then I will speak about ESG recommendation, the technique, common mistakes during tattoo, and conclusion. So in Russia you have a great history about tattoo. I know this is a strange, quite particular tattoo, but the important thing is that some tattoos like skulls or the angels or the castle have a proper significance. So in this case, tattoo is important to identify what is the crime that the prisoner committed. In our world, in the endoscopy world, tattoo is important to identify future lesion for future resection or future surveillance. Now, tattoo should be used in the colon and in the small bowel. And why? We should use tattoo when we encounter cancer and when we encounter dysplastic lesion. So cancer, because we want to send the patient for surgery and we need to allow our surgeon to perform a good resection, not too large, but very precise resection, possibly on laparoscopy. So otherwise we can, when we encounter a lesion in the colon, in the small bowel, that we are not able to resect, we can tattoo and refer to another endoscopy center, or we can resect ourselves and then place a tattoo as surveillance for the future to check where the lesion was. So now let's talk about the ESG recommendation. There are 4 recommendations. So the first one, as we said, is that we tattoo close to the lesion to find the lesion for follow-up or send them to surgery. The second recommendation is that we should tattoo with sterile carbon particle suspension as preferred tattoo agent. Which is that? This is a sterile agent, is biocompatible, is a pre-packaged suspension and purifying fine carbon particle. And there is only one agent available now, which is Spot, which is commercialized by GI Supply. This is the only tattoo which is approved by European Society of Gastrointestinal Endoscopy and is also approved by the FDA administration. So this is in the picture the evolution of Spot. It's Spot X, which is 30% darker than the previous one. So it's even more useful. And it will stand, the study suggests, for 12 years. Now, tattoo should be accessible, easy to use, and safe. And this is the case because the case of infection are extremely rare. Third recommendation is that before you inject tattoo, the injection should be made with a saline. So you inject in the submucosal space, so you have a bleb, and then you swap the syringe and you inject the tattoo. So the reason behind that is because you need to inject the submucosa, not the muscularis mucosa, not the muscle layer, not the peritoneum, the submucosa. And only injecting the saline, it's the best way and the safest way. Finally, the last recommendation for ESG, tattoo should be placed at least 3 centimeters distal from the lesion. So no more than 3 centimeters closer. So 1 centimeter is no good, 2 centimeters is no good, it's too close, 3 centimeters or more. Because you need to keep in mind that if you inject underneath the lesion, and I will show you some video, then we will cause many difficulties, both for the surgeon and also for the pathologist or for the endoscopist, depending on the kind of lesion we are speaking about. And you need to inject distally, so rectal side, and this needs to be, you need to take picture, include the picture in your report and write exactly where you tattoo. Technique. Now, this is the technique I was speaking about. So this is a tattoo that I have performed in my endoscopy unit in London at the Royal Free Hospital. So this is this plastic lesion, probably was a bit pattern 3L. So we are placing a tattoo on the contralateral wall. So we first inject with a saline. As soon as you have a nice bled, what you do is you keep your needle in place, you ask your nurse to swap syringe, and as soon as you're happy, you can see the color is changing and you have a nice tattoo. Now, what is important when performing this technique is that you have to keep 30-45 degrees angulation, that you need to, as we say, at least 3 centimeter distance, and especially when you find cancers, you need to do 3 or 4 tattoos in the same area, so that you have circumferential tattoos. So this is a video about circumferential tattoo. Why we need to do circumferential tattoo for cancers? Because for laparoscopic surgeon, it's very important to identify the tattoo, and if you leave a tattoo, maybe if you perform only one tattoo, maybe it might lay in the blind part of the colon, and the laparoscopic surgeon wouldn't be able to see it. With 3 or 4 tattoos, they will see for sure. So here we place one tattoo, we repeat exactly the same technique over and over. Between one tattoo and the other, it's important that you purge your needle, so that after you inject tattoo, you have you purge your needle outside or inside the colon, and then you can repeat the procedure again and again. So, and this is going to be the final results. So as you can see here, you have 1, 2, 3 tattoos, and circumferentially for the external part, it's very visible. So this was what you want to achieve for your surgeon. So here there are 2 tattoos, here there are 1 tattoo. So it's quite visible, it's quite nice for them to have this reference. And this is a protocol that was created at St. Mark's Hospital, which is a very important international hospital where I was a fellow almost 8 years ago. And so the important part, if you see the first draw, you will notice that the cecum and the rectum are not included in the picture. Why? The recommendation is you don't tattoo the cecum and the rectum. Why? The cecum because, I mean, the cecum has some marker, which are internationally recognized, which are ileocecal valve, appendix, and the 3 irradiate cecal folds. So if a lesion is in the cecum, and you're sure it's in the cecum because you're documenting with the picture, everyone will find the tattoo, the lesion in the cecum. And if you tell this to your surgeon, I mean, they will be able to find it very easy. So there is no need for tattoo in the cecum. Why not in the rectum? Because again, the rectum are the first 12 centimeters of the colon, so it's very quite clear and obvious where the lesion is. What I suggest you to do is to take measurement. The measurement should be from the lesion to the internal anal verge, so that you tell exactly your surgeon what is the distance, and this might change completely the surgical approach. So going forward, we also apply tattoo in the small bowel, but there is a big difference between the small bowel and the colon. The small bowel is a very thin organ. There's a 3 millimeter in some part of the small bowel, so as soon as you inject, the injection tends to spread very rapidly all over the wall. And also when you go down with the endoscope, especially if you are quite deep in the small bowel, the position sometimes is not very stable, so you should find before starting a nice and stable position. Sometimes inflating the balloons help you a lot. This is another video about a small bowel tattoo, which we perform in my center, which is a very busy tertiary referral center, one of the busiest in Europe. So this is underwater double balloon endoscopy. So here is the needle. We inject this. As you can see, as soon as we inject this, the saline will spread around the wall very quickly. And so here we ask the nurse to swap, always leaving the needle in the lesion. You never take the needle out because sometimes it's very difficult then to get again into the submucosal space. And this is the result, quite nice result. So when do we use tattoo in the small bowel? We use tattoo for cancers, for submucosal lesion as a carcinoid or as cyst. We use for stricture that are not endoscopically amenable for dilatation. So we're speaking about stricture longer than 5 centimeters, ulcerated, and also we use them for macula diverticulum. And this is exactly the case. So this is a patient, a young patient who was bleeding. We did a capsule which revealed the mecha, and as you can see here, there is the mecal, and here there was the lumen. And we place the tattoo distal to the mecha, and the patient had operation a few days afterwards. This is another double balloon enteroscopy. This is a carcinoid that we found in the small bowel. We tattoo it. In this case, I decided to tattoo it distally and also proximally. So because there were 2 carcinoids, and I wanted to give to my surgeon the exact point of the exact segment where the carcinoid were involved. And we then took biopsies and we placed a clip as a reference for radiological management, so that the surgeon knew if the carcinoid was maybe in the ileum or in the jejunum by CT scan. So this is the specimen. So as you can see here and here you have the tattoo. And the specimen is, I think it's about 10 centimeters, so it's a very small specimen, so it's a minimal surgery, minimally invasive surgery. And this is when the pathologist opened the specimen, so you can see the tattoo here, you can see the carcinoids here, and you can see the clips here. So now let's speak about the common mistakes, okay? Because making tattoo, it's easy. It's not rocket science. You need some only few tips and tricks that you have to follow, but there are common mistakes, and you will be amazed to see how often you encounter this mistake. So the mistakes are: 1, and you will laugh at this, but it's true. The endoscopist forgot to tattoo the lesion. So no tattoo, you send a patient, you see a cancer, you take biopsies, you come out, and then you realize that you forgot to place a tattoo. This is a very common mistake. The injection directly on the lesion, which we said is the last thing you want to do. And also, the last thing you want to do is to inject without saline. This is to be absolutely avoided, because if you inject in the peritoneum, 1, there is a risk that you can cause peritonitis, although it's extremely rare, there is. And second, the risk is that you will spray the peritoneum with tattoo, and when the surgeon will perform the operation, will see everything dark and will hate you. And then you have to avoid cecal rectal tattoo, but still there are endoscopists who tattoo the cecum and the rectum. Now, those are some videos about common mistakes. So this is a polyp that was referred to our institution. Oh, sorry, I just skipped that. And what you can see here, very is that the tattoo was all over the place and was close to the lesion and was underneath the lesion. So first mistake. Second mistake, this was a follow-up after a resection. As you can see, there is the scar here, and tattoo was completely around, always all around the scar, and that made the evaluation of the scar a bit difficult. And if you have a recurrence in this case, it's even more challenging to resect the lesion. That's another case. This is an LST mixed type that we had in our institution. So as you can see, it was referred to us for an ESD. And the tattoo was close to the lesion, but also underneath the lesion. And as you can see from this video, we started to do an ESD. And we completed the ESD. But the problem was that as soon as we start cutting, making the incision, you see here that you will see the tattoo very soon, and the problem is that these make very difficult to identify the right plan where to cut, and it can be also very risky and highlight the risk of perforation. So this is the tattoo, you can clearly see. So when you inject methyl indigo carmine here, it mixes with the tattoo and you don't recognize the submucosal from the muscle layer. So it makes things much complicated. And going forward with the resection, what also we've noticed was that there was a lot of fibrosis. So all these whitish fibers here are fibrosis. So there was a scar because of the tattoo, and it made our resection very challenging and very difficult. So it slowed down things a lot. So in conclusion, tattoo facilitate lesion localization. So please use tattoo for cancers when you refer patient for surgery, for endoscopic resection if you refer the patient to another center, and for endoscopic surveillance after resection of this lesion. Please choose the right tattoo, so please choose the one recommended from the European guidelines and from the evidence, which is spot X, and please tattoo at least 3 centimeters distant from the lesion, 3 or more. When you have a cancer, please place 3 or 4 tattoos, and avoid the common mistake that we spoke about. I finally conclude saying that you are all welcome to the Advanced Endoscopy Masterclass in London in 2019 from the 3rd to the 5th September. I'm one of the 2 directors together with my good colleague Dr. Despot. We had a stellar faculty. This was the faculty of last year, but you'll have an even more big faculty next year. We have ESD, ERCP, directed by course, directed by Yamamoto Sensei, and ERCP US. So thank you so much. Thank you again for the invitation. Thank you.
Presentation for invitation. Михаил Павлович вручает традиционный дипломный подарок. Если у кого-то есть вопросы, коллеги, подходите к микрофону, пожалуйста.